Welcome everybody again after the break. Let us turn to the second session. Please welcome our distinguished moderators, Professor Marion Rabant from Paris and Professor Ryszard Grenda.
Marion Rabant is an assistant professor at the Department of Pathology at Necker-Enfants Malades Hôpital in Paris. She is a member of the Paris Transplant Group, involved in several BANF working groups, and the chair of the Pediatric Transplantation Pathology Working Group of the European Rare Kidney Disease Reference Network.
Professor Ryszard Grenda is a head of the Department of Nephrology, Kidney Transplantation and Hypertension in the Children's Memorial Health Institute in Warsaw. Professor Grenda is the past president of the Polish Association of Pediatric Nephrology. He was a member of the Nomination Committee of International Pediatric Transplantation Association and member of the Executive Board of the European Society of Pediatric Nephrology. Professor Rabant, Professor Grenda, we are all ready for you.
Thank you very much. It's a great honor for me to be here and to moderate this second session with Professor Grenda. And I will first introduce Professor Cynthia Nast, that you all know. She's a professor of pathology at the Cedars-Sinai Medical Center at UCLA. She's specialized, of course, in renal pathology and electron microscopy. She was a former president of the Renal Pathology Society, and she published a lot of studies on glomerular disease, which help us a lot to increase the knowledge of renal pathology. And she will present the first presentation of this session about technical aspects, including new developments in renal pathology. Professor Nast, is for you.
Hello, my name is Cynthia Nast, and I'll be spending the next 20 minutes talking about technical aspects and new developments in renal pathology. Standard renal pathology includes light microscopy, immunofluorescence or immunohistochemistry, and electron microscopy, with IHC and in situ hybridization often being used for specific reasons. The standard light microscopy fixative is formalin, which is good for immunohistochemistry, DNA, RNA, and pronase immunofluorescence, with morphology, which is okay but not ideal. Paraformaldehyde is similar, although slightly less good for pronase immunofluorescence. Alcoholic Bouins gives excellent morphology, but is somewhat limited with immunohistochemistry and particularly for RNA. Immunofluorescence is often done on Zeus solution or Michel solution preserved tissue, which is nice because it can be transported at room temperature for days, but there may be reduced antigen availability. Snap freezing is ideal for antigen preservation, but can be technically difficult, especially if tissue transport is needed. And the standard fixative for EM is glutaraldehyde, although formalin can be used if necessary. Karnofsky's is actually the best, but it's less available, takes longer to make, and is not typically used anymore. The standard techniques in renal pathology for light microscopy include stains for PAS, which stains basement membranes and mesangial matrix, Tam-Horsfall protein, and proximal tubular cell brush border, the Jones periodic acid methenamine silver, which stains matrix and basement membranes, Masson's trichrome, which stains matrix, basement membranes, collagen, and Tam-Horsfall protein blue, and immune complex deposits and plasma proteins orange, while H&E is best for nuclear detail, viral inclusions, crystals, and eosinophils. Congo red, infectious, and immunohistochemistry stains are used as needed. Here are examples of well-done stains on well-sectioned tissue. The PAS stains the basement membrane and mesangial matrix material, as does the Jones methenamine silver with black. In the trichrome stain section, collagen, basement membranes, mesangial matrix are blue, with the orange fuchsin positive insudates here, deposit stains similarly, and the brown nuclei, while an H&E stain is good for things such as nuclear detail in this polyoma virus infected kidney transplant. Many laboratories do routine immunofluorescence, although some do immunohistochemistry. The advantages of IF include little background staining. It's technically simple, fast, and low cost with many suitable antibodies and has good sensitivity and specificity. Disadvantages are that you have different areas in the light microscopy and the IF, so you're not exactly seeing the morphology of what is staining. The staining is not permanent, so the positive stains need to be photographed, and there's expensive storage if you store the slides for a long time, which we don't. We discard them after about 4 months, and you need an additional tissue sample. Immunohistochemistry, sort of the opposite, same tissue areas with permanent staining, better morphological detail, and it's high sensitivity, but it's really poor specificity. With a lot of background staining, it's more expensive, it takes longer, more limited antibodies, so most places do immunofluorescence. Electron microscopy is an important part of kidney biopsy evaluation. In studies, it has been shown that it's essential for diagnosis in up to 21% of adult kidney biopsies and provides important diagnostic contribution for up to 25%. So between 45 and 50% of the time, it's actually quite significant. In transplant biopsies, it's critical for identifying early transplant glomerulopathy, or CG1A. And this is important because early treatment may prevent progression of this disease. In children, it's more important than in adults, and especially if you look at the younger age children, here 0 to 3, EM provided crucial or important information in essentially all of them, and even up to 18 years of age, approximately 60 to 65% benefit from having EM performed. Salvage techniques can be used in renal pathology. If there is no cortex or adequate number of glomeruli by light microscopy, the EM light microscopy thick section can be used, or the frozen for IF can either be reprocessed for light microscopy, or frozen sections can be post-fixed in formalin and stained with any of the light microscopy stains. If the piece for IF has no cortex or glomeruli, the light microscopy FFPE, or formalin-fixed paraffin embedded tissue, can be used for IHC, or it can be protease digested for immunofluorescence, and I'll discuss that in a moment. On EM, if there's no cortex, glomeruli, or findings of interest, the specimens for light microscopy or frozen tissue for IF can be reprocessed for EM. And I have protocols for all of these. I'll have my email on the last slide, so if you want a protocol, just contact me and I'll be happy to provide it. So immunofluorescence on formalin-fixed paraffin-embedded tissue, or FFPE, can be done using a protease digestion process, which can be done either using pronase or protease K. Protease K may be able to unmask or identify complement in the glomeruli better. And the diagnostic findings of using this technique range from 20% with anti-GBM, which is rather difficult to identify on IF on FFPE sections, to very common, so 100% for lupus or some immune complex genes like IgA. So if there are no glomeruli for IF, as I've indicated, this can be used. If you have C3 glomerulonephritis or you're suspecting masked deposits, this can unmask hidden immunoglobulin or light chain deposition. It also is useful for uncovering intracytoplasmic light chains, which often are not identified by immunofluorescence, although these also can be often identified by routine immunohistochemistry, or IHC. There are limitations. It's less sensitive than regular IF. There is usually poor identification of C3 and of IgG and anti-GBM disease. It's been variably seen to be positive in membranous, and it may not detect weak staining because it is less sensitive. So there are some additional techniques for diagnosis, pathogenesis, and prognosis, other than the standard ones that I've just reviewed. We have developed a technique using frozen sections that are post-fixed in formalin to enhance antigen expression both with and without the need for protease digestion. So, for example, this is a case of PLA2R membranous where there were no glomeruli for light microscopy, so we did a frozen section post-fixed in formalin and get absolutely beautiful staining. Sometimes if the antibody is not working well on the FFPE, which happens, and there's been some discussion amongst pathologists, renal pathologists about this, this can be used to have better positivity with the antibodies that are being used. So here's an example of amyloid, which stained for LEC2 here nicely in the tubulointerstitium and a little bit in the glomeruli. So it can be used again if there are no glomeruli or if the stains are not working well. And again, if you would like a protocol for this, I'd be happy to provide it later. This is an example of a 22-year-old female who had serologic studies suggestive of lupus with an elevated serum creatinine, nephrotic range proteinuria, and hematuria. The immunofluorescence disclosed C3 only, and there were no glomeruli for light microscopy. Using the formalin-fixed frozen sections with pronase digestion, it unmasked an IgG kappa membranous-like glomerulopathy. So this immunofluorescence on frozen formalin-fixed sections can be used without and with pronase digestion. IgG subclass staining is another technique which is fairly common but is used in special circumstances. We usually think of it in this context of membranous nephropathy to try and identify primary versus secondary forms of membranous nephropathy. And looking at the subclass staining, IgG4 is more often positive with PLA2R and thrombospondin. It's dominant or codominant with bovine serum albumin-associated membranous in children, and maybe codominant, interestingly, in graft versus host disease, and dominant in transplant recurrence, because this is usually a primary type of membranous nephropathy. NEL1 seems to be dominant for IgG1, bringing into question whether this is really a primary type of membranous nephropathy or not. So there is some use, although it's certainly not 100% in membranous nephropathy. Other settings in which IgG subclass staining are useful is when there's a monoclonal gammopathy or a B-cell lymphoproliferative disorder with IgG deposits. And so it can be used to identify if the IgG deposits are in fact monoclonal, as with immunotactoid, heavy chain deposition disease, type 1 cryo, heavy chain associated amyloid, although with amyloid you have to be aware of nonspecific staining. Proliferative glomerulonephritis with monoclonal immunoglobulin deposits to see if they're really monoclonal. If these seem to be light chain restricted, there may be IgM deposition as well, which may mask monoclonality. So by doing IgG subclass staining, you can see if the IgG is monoclonal. And then, of course, an IgG4 related disease, or if there are tubular base or membrane deposits other than lupus. Alpha-5 collagen chain staining in Alport is another technique which is useful but with limitations. It can be helpful in terms of prognosis, mode of inheritance, and correlates with severity of the GBM changes on EM. The limitations are that it's normal in autosomal dominant Alport syndrome, and if there's a compound heterozygote autosomal recessive Alport syndrome. It's often normal when disease presents or is identified in adults, even if it's true Alport syndrome. And EM, in fact, is more diagnostic for Alport syndrome. And the type 4 collagen staining often does not differentiate between thin base or membrane disease and Alports. So it is most useful in children, but can occasionally be helpful in adults. Doing genetics is really the best way to figure out if there's Alport syndrome or if there's GBM changes as part of FSGS. This is an algorithm looking at alpha-5 staining in Bowman's capsule, negative or positive, in glomerular basement membranes, in association with laminin fibronectin GBM staining, and you can look at that at your leisure and how it relates to the diagnosis of Alport syndrome. Laser capture microdissection tandem mass spectrometry is a technique used for both diagnosis and discovery in renal pathology. A prime example is membranous nephropathy, where this technique was used to describe NEL1 and XS-DOSIN2, which now have antibodies available for diagnostic use. In the recent American Society of Nephrology meeting in October, an additional 4 antigens in membranous nephropathy identified with this technique were described, including neural cell adhesion molecule 1, semaphorin B, HTRA1, and protocadherin 7. This technique was used to identify DNA JB9, which is now of routine diagnostic use in fibrillary glomerulonephritis. When amyloid type cannot be identified by immunohistochemistry, it often is submitted for mass spec to identify the amyloid type as part of routine diagnostic workup. This technique has also been used to identify C3DG as a prominent component in the electron-dense deposits in C3 glomerulopathy and to identify IgD heavy chain deposition disease. In situ hybridization is another technique that can be used both diagnostically and in discovery and research. RNA-scope is a recent technique which amplifies signals and suppresses background, allowing for much more readability in RNA staining. It uses FFPE with a chromogen or fluorescence label, and up to 4 RNA targets can be identified per slide. In some settings, it may be more sensitive than IHC, as in this transplant biopsy stained for polyomavirus, where the RNA scope identified much more virus than routine immunohistochemistry. It is also possible to multiplex immunofluorescence for protein and RNA in situ hybridization. Digitized whole slide images can be created for analysis to identify the cellular target of the transcript and quantitate RNA and protein signals. In this example, looking at cell-mediated transplant rejection, it demonstrates the ability to look at what's expressed as well as the cells that are expressing it. Other future directions with research applications include optical clearing, which renders tissue translucent by equilibrating the refractive index throughout a sample to reduce the light scattering. And this enables one to see thick tissue slices or even whole kidneys, particularly of small experimental animals like mice. And here's an example of that. Multiphoton microscopy is a form of high-resolution immunofluorescence imaging of living tissue with sections up to 1 millimeter thick, and this can be 2-photon or 3-photon. It's based on a nonlinear excitation effect, again with less light scattering, allowing better resolution. The background signal is suppressed with an increased depth of penetration, and there's reduced photodamage to this living tissue. And here are some examples of this in the renal tubulointerstitium. Super resolution microscopy is another current research application. Don't know if it'll ever have practical use in routine diagnosis. It produces high resolution images with visualization with an optical resolution down to 10 nanometers, so potentially could replace electron microscopy, at least in some settings. And it breaks the diffraction limit by temporally or spatially modulating the excitation or activation light. And here's an example of sort of routine immunofluorescence, and here is using the super resolution microscopy with this very fine separation of these different components. And that leads us to artificial intelligence, which is really one of the other things at the forefront of the pathology revolution, if you will. And I think Dr. Barasona may be going into this in some detail, so I'm not going to go into it in too much detail. In this, you have a kidney biopsy. The blue here is the sample flow. The kidney biopsy is processed into your special stains, light microscopy, immunofluorescence, EM. These all are digitally imaged, the IF and EM, when you first look at them, and then the slides can undergo whole slide imaging. They can go into a training data set And you can have supervised or unsupervised analysis with convoluted neural networks, and then come out with machine learning, which can then identify these changes on digitally imaged slides. There are some caveats to this. The biopsy, of course, has to be adequate, and you have to have consistency of your pre-analytic variables such as fixation, sectioning, staining quality. The scanner consistency, resolution, and equipment cost are issues. Storage space. There's time creating image annotations for so-called ground truth, so what you have to train the machine on. Standardization of computer algorithms, and then awareness of software and system upgrades, and monitoring of decision accuracy, as well as equipment cost. But clearly this is progressing, and this is a way a lot of pathology will be going, including renal pathology. Computers actually can be used to stain digitized unstained sections. So FFPE sections can be deparaffinized, cover slipped, and then autofluorescence images captured with a standard immunofluorescence microscope. And then the CNN, or convolutional neural networks, which have been trained to match these typical bright field stains against the autofluorescence images, can be applied. So here is the autofluorescence image. This is one which then went to a virtual stain, and then here it went to a histologic stain for the Masson's trichrome, and you really can hardly tell the difference there. So this might be a way of having faster production of slides with less staining variability, and also because you only have to make one unstained section, you preserve the FFPE tissue for additional studies. And lastly, doing descriptive look at EM pathologic and other features can have novel predictive value. I won't go into this too much because I think Dr. Barasona may be discussing this, but just very briefly, podocyte microvillus transformation was statistically associated, and podocyte effacement and endothelial cell honeycombing had a trend to be associated with the remission of proteinuria, whereas thickened glomerular basement membranes and the loss of endothelial cell honeycombing were associated with decline in EGFR. So looking at these features that we don't typically look at may give us information. So I hope this has been a useful overview. I thank you for your attention, and please contact me if you want any of the protocols I discussed.
Thank you very much for this very nice overview, Professor Nast. It's really interesting to see all the new tools that we will be able to use in the next years. So I'm sure that there is a lot of people with questions to you, and the questions will be after the next two speakers. So I will next introduce the second speaker, Dr. Krzysztof Kiryluk. He's an associate professor working at the Division of Nephrology in the Department of Medicine at Columbia University. He specializes in the treatment of chronic kidney diseases, glomerulonephritis, and inherited kidney disorders. And his research aims to define genetic factors contributing to the risk of kidney disease. So now, Dr. Kiryluk, you will present us your presentation about genetics in renal pathology. Thank you.
Hi, my name is Krzysztof Kiryluk, and it's a pleasure for me to speak at the 4th International Renal Pathology Conference in Warsaw, Poland. Of course, I truly regret not being able to deliver this talk in person and visit my home country in the process. Nevertheless, I'm very grateful to the organizers of the conference for inviting me to speak about my work. And I'll discuss today my views on the role of genetics in kidney pathology and kidney diagnostics. So I'd like to start my talk by summarizing how geneticists like myself think about human disease, including kidney disease. We typically think in two categories of genetic disease. We think about monogenic models, where rare variants or rare mutations with large effects cause a phenotype. And on the other end of spectrum, we think about complex traits or polygenic diseases caused by many common variants with small effects that cumulatively cause a disease. And of course, monogenic diseases have been studied effectively by sequencing and exome sequencing, especially in recent years, and polygenic models have been addressed by genome-wide association studies. And throughout my talk, I'll address how both of these methods, exome sequencing and genome-wide association studies, could affect kidney disease diagnostics. So let's start with exome sequencing and its applications to Mendelian forms of kidney disease. So exome sequencing is a well-established methodology now, but it's important to understand its limitation. Exome sequencing refers to the sequencing of the coding segment of the genome, and each time you perform an exome sequencing experiment on an individual genome, you generate roughly 10,000 protein-altering variants. So it's very important to apply a stringent set of filters in order to narrow down your search space to identify a causal variant in a given case. These filters really involve a variety of different metrics, including minor allelic frequency filters, which are probably the most important under the assumption that common variants are unlikely to be causal of a rare disorder. So you filter out the common variants, you annotate the other variants by looking them up in various databases such as OMIM or ClinVar. There are also bioinformatic algorithms that help you prioritize these variants, but ultimately it comes down to also clinical interpretation and the observation if a given candidate variant is actually segregating with the phenotype and the pedigree of a patient. And final diagnostic call really requires an expert manual curation. So this is kind of the general approach. And of course, recently there was a lot of interest in the application of exome sequencing for the diagnosis of kidney disease. So we were very interested in the application of diagnostic exome sequencing for the general population of patients with chronic kidney disease. And for this purpose, we recruited over 3,000 patients from CKD clinics, and we performed exome sequencing in collaboration with the Institute for Genomic Medicine at Columbia. And interestingly, roughly 9.3% of the entire cohort carried a pathogenic or likely pathogenic variant consistent with monogenic disease. This is using very stringent criteria established by the American College of Medical Genetics. And when we looked at the individual mutations, we cataloged 66 distinct monogenic disorders in this cohort. And you can see that the pie chart is dominated by polycystin mutations, but there's a large fraction of patients with collagen 4 mutations, and the remaining 1/3 of the patients have usually rare conditions which were typically undiagnosed in this cohort. And this slide highlights some of the clinical spectrum of collagen 4 disorders in our cohort. There were 91 CKD cases diagnosed with collagen 4 mutations by exome sequencing. And I think the important observation here is that the majority of them did not have a clinical diagnosis consistent with Alport syndrome or thin basement membrane disease. And you can see that a large fraction of these patients had unknown etiology of their kidney disease, or they were called to have other GN type or FSGS. And of course, early genetic diagnosis could have potential treatment implications since these patients are unlikely to respond to immunosuppressive medications. So I think this really highlights that exome sequencing could have a profound impact on the clinical diagnostics in nephrology. So next, I would like to discuss approaches used to study the genetics of polygenic traits or complex traits. And here, GWAS is the main discovery method. GWAS involves genetic profiling of a large number of cases and controls with SNP chips or by genome sequencing. And it really comes down to comparison of genetic variant frequencies between cases and controls. Because the testing is performed across the entire genome, it involves multiple tests, and stringent statistical methods have been established to declare genome-wide significant loci. But I think defining significant loci is only the first step in a genetic discovery, and additional studies are typically required to define specific causal variants for each GWAS locus. and how these variants affect gene expression and gene function. What are the causal genes? Which cell types do they operate in? What pathways do they perturb? And how do these genetic perturbations actually lead to the disease process? So what is the motivation behind GWAS studies, and what type of useful insights can emerge from GWAS discovery studies? First, GWAS, in my opinion, are very helpful in quantifying the overall contributions of common variants to the disease risk. So they really provide a direct insight into the genetic architecture of a complex trait. A term called SNP-based heritability refers to the fraction of disease risk that is attributable to the universe of common variants across the genome. And another term to refer to this is polygenic risk. And so polygenic risk could be potentially helpful when defined by well-powered GWAS for the diagnosis of a complex trait, for risk stratification, and also for predicting treatment responsiveness. Another really important benefit of GWAS is the fact that you can actually gain unbiased insights into the disease mechanisms. This involves fine mapping studies which will define the causal variants and causal genes underlying GWAS loci, but ultimately the identification of causal pathways could enable design, kind of a rational design of drug targets, of new drugs that target these pathways, and also could facilitate potential repurposing of known drugs that are in use for other conditions. So this is actually a critical advantage in our field for some of the understudied glomerular diseases, for example, where really targeted treatments do not exist. So as an example of a disease in nephrology where GWAS provided really interesting insights into the pathogenesis is membranous nephropathy. So as all of you know, membranous nephropathy is a disease of anti-podocyte antibodies, and multiple antigens for membranous, multiple podocytes antigens have been now defined. I think the major progress came from the identification of the most common antigen, phospholipase A2 receptor. Antibodies against phospholipase A2 receptor explain roughly 80% of cases. And then there are multiple other antigens, some of them revealed during the ASN this year, that appear to also be involved in a smaller fraction of cases. And these are the results of our genome-wide association study for membranous nephropathy that we just published this year. This is a very large multi-ethnic study that was made possible by contributions through a very large number of different nephrology centers. We involved nearly 4,000 cases of primary membranous and over 9,000 controls to execute the study. And you can see in this Manhattan plot that there are 4 genome-wide significant loci: a previously discovered HLA locus with the largest effect and most statistical significance, but also phospholipase A2 receptor locus, also previously reported, and of course encoding the primary or the most common antigen in primary membranous nephropathy. And these 2 loci have previously been reported to interact, and we recapitulated this interaction in the study as well. But we also discovered 2 additional novel loci: the locus on chromosome 4 encoding NF-kappa B1, a component of the NF-kappa B signaling complex or transcriptional factor that regulates inflammatory responses, and IRF4 locus also involved in the regulation of inflammatory responses. I think what was really remarkable about this is that when we actually sum up the contributions of all common variants across the genome, so estimate the SNP-based heritability, it's actually really high, in the range of 36 to 43%, depending on the population that you're studying. And in addition to this, GWAS loci alone, these 4 GWAS loci, explain in the range of 25 to 32% of disease risk by themselves. So this is a somewhat unusual example where the polygenic contributions and common variants actually account for a very large fraction of disease risk. And I think this really highlights how helpful GWAS study could be in providing insights about the genetic architecture of a disease. As part of the same study, we've done a lot of fine mapping of the HLA locus to try to figure out the specific classical HLA alleles that predispose to membranous. We defined some ancestry-specific effects, so we did this analysis in East Asian cohorts and European cohorts separately. And you can see here in the frequency plots in the bottom left that DRB1 1501 and DRB1 0301 represent two major risk alleles in the East Asian population, but the major risk alleles in Europeans are slightly different. Mainly DQA1 0501 represents the allele conveying highest risk in Europeans, and but DRB1 0301 effects are shared between East Asians and Europeans. So this was also an additional insight that perhaps the epitopes that are being presented by HLA class 2 molecules might differ between East Asians and Europeans, and clearly the disease might be different because of that. We also tested for genetic interactions between HLA and phospholipase A2 receptor locus, and we observed that the DRB1 1501 and DRB1 0301 alleles, major risk alleles in East Asians, strongly interact with phospholipase A2 receptor locus, and you can see the odds ratios are markedly higher on the left-hand side for individuals that are double homozygotes for risk alleles at these loci, whereas in Europeans the interaction was much weaker, and actually when we dissected the contribution of DRB1 and DQA1 genes, it seemed like only DRB1 0301 actually interacted with phospholipase A2 receptor to produce excess risk in Europeans, whereas DQA1 effects were really additive with phospholipase A2 receptor. So clearly quite complex genetic determination. I think that what's really striking about this is that this interaction translates into very large odds ratios, which then could be used potentially as a clinically meaningful predictor of risk and perhaps even a diagnostic tool. To follow up on these observation of large effect sizes, we designed the polygenic risk score for membranous. The risk score was really expressed as a sum of risk alleles weighted by their effect sizes from GWAS, and it included also an interaction term between HLA and phospholipase A2 receptor loci. These graphs depict odds ratio of disease as a function of the risk called decile, and the odds ratios are expressed in relationship to the lowest decile. And you can see that individuals in the top 10% of the risk score distribution have a 20 to 40-fold increased risk of membranous compared to the lowest decile. So, and you can also see that these observations reproduce across different cohorts, including external validation cohort, which was not included in the original GWAS study. So we also had serum samples for a large number of cases and controls included in our GWAS studies. So we measured phospholipase A2 receptor antibody levels by ELISA in these cohorts. And then we quantified the sensitivity and specificity of the test. We confirmed that at the manufacturer recommended threshold of 20 units per milliliter, this test has excellent 100% specificity in both East Asian and European cohorts. Yet the sensitivity of the test, as you can see, is rather low, and it ranges from 57 to 60%. So this test is missing a lot of true membranous cases. When we lower the threshold to actually the lowest detectable signal, which is 2 units per milliliter, you can see that the diagnostic specificity goes down and the test becomes not that helpful from the standpoint of diagnostics. So then we asked the question, can we actually do better by incorporating genetic information into this diagnostic test? So next we evaluated the diagnostic performance of genetic risk score after stratification by phospholipase A2 receptor antibody status. And these are receiver operating curves stratified by phospholipase A2 receptor antibody. And you can see that the GRS is most predictive of the disease status in individuals who are phospholipase A2 receptor antibody positive using the stringent cutoff of 20. However, you can also see that GRS remains predictive and provides some diagnostic information in individuals who are phospholipase A2 receptor antibody borderline, and also in individuals who are phospholipase A2 receptor antibody negative. So next, we wanted to enhance the ELISA test by adding the genetic information. And in the same analysis, when we actually devised a combined score that accounts for phospholipase A2 receptor antibody status and genetic information, in those who were, of course, antibody positive, this combined risk score is perfectly diagnostic. But in those that were borderline previously, the sensitivity of the test improved significantly, shifting some of these patients into the proper diagnostic category. And we calculated that we are achieving roughly 22% net reclassification improvement by adding genetic information to the serum ELISA test in our replication cohorts. In summary, GWAS provided several important new insights into the genetic architecture of membranous nephropathy. We demonstrate that 4 GWAS loci explain 25 to 32% of disease risk. This is a very large fraction. And in fact, we also demonstrate that incorporation of genetic information into the interpretation of ELISA test for phospholipase A2 receptor antibodies can enhance the non-invasive diagnosis of MN, mainly by increasing the sensitivity of the test. We also provide evidence for ethnicity-specific effects, suggesting that perhaps membranous is a slightly different disease in East Asians compared to Europeans. And finally, we discovered 2 new genome-wide significant loci that point to NF-kappa B pathway and also interferon signaling, highlighting that these pathways might represent potential novel therapeutic targets. And this figure, derived from our recent review in CJS, and summarizes some of the genetic risk loci for glomerular disorders other than membranous, including IgA nephropathy and steroid-sensitive nephrotic syndrome. I think it's really interesting to look across the spectrum of different glomerular diseases, and you can see that these diseases all share HLA associations. However, when you actually resolve classical HLA risk haplotypes, each of these diseases actually is associated with a unique set of HLA classical risk alleles, really suggesting that the immune mechanisms underlying these disorders are distinctly different. In addition, I want to point out that present GWAS studies for glomerular disease still have multiple limitations. Small sample size is a big problem, especially for studies performed in pediatric populations, and really precludes us from identification of effect sizes that are modest or smaller. So there's a lot of room for improvement over there. Also, present GWAS studies for glomerular disorders are really dominated by European and East Asian cohorts, and we really have no idea if these findings actually replicate in patients, for example, of Latin or African American heritage. And many of the glomerular disease types, which I think are very interesting from genetic perspectives, have not yet been studied by GWAS. So I think a lot more work remains to be done in this specific area. I also want to mention that we're actively involved in genetic studies in the CureGN cohort. This is a large prospective cohort of 2,400 patients with primary glomerular disease diagnosed by biopsy and recruited across the United States and Canada. And I want to give a shout out to my Polish colleagues at the University of Warsaw, because Warsaw represents one of the CureGN recruitment sites. At Columbia, we are performing genome sequencing and also blood transcriptome sequencing of the entire cohort. And I think this type of a unique data set will allow us to address many important questions in the genetics of glomerular disease. For example, we'll be able to assess the diagnostic yield for Mendelian disorders in glomerulonephritis. We'll be able to test for clinical and pathologic correlates of polygenic risk defined by prior GWAS studies. We'll be also able to assess functional effects of risk alleles on blood transcriptome. All of these are important questions. And importantly, we'll also provide an open access resource to the community, since this entire data set will be released publicly. With this, I would like to thank my lab members, many of whom were involved in the analyses that I discussed today. I would also like to thank the Polygenes Network, which is a network of Polish nephrologists and geneticists who send us really interesting cases for inclusion in genetic studies of kidney disease. I would like to thank my colleagues at Columbia, especially Ali Garavi, who was really behind the exome sequencing study that I discussed, and my pathology colleagues, especially Dr. Dagari at Columbia, and many, many members of the membranous nephropathy network that allowed us to perform genome-wide association studies, including my colleagues from Poland, as you can see highlighted in yellow. Thank you very much for your attention.
Thank you very much for your very interesting talk, showing us how genetics and GWAS study can help us better understand the pathophysiology of renal disease. It's really interesting. So you also will have questions after the next speaker. So I will now introduce Dr. Isaac Stillman. He's an associate professor at the Department of Pathology at the Beth Israel Medical Center in the Harvard Medical School in Boston. So Dr. Stillman is going to show us the prognostic value of renal biopsy findings. Thank you, Dr. Stillman.
I'd like to thank the organizers for the invitation to speak on this topic, something that I believe needs more attention in our clinical practice. I was very much looking forward to visiting Warsaw, a city of sages, and it is only a small and insufficient consolation that at least my PowerPoint file is making it there. It is my fervent hope that someday we may all be together in the same physical space. Our colleagues in neoplastic pathology place great emphasis on the histologic risk factors present in a given malignancy. To do right by our patients, nephropathologists need to pay more attention to prognosis, because patients want to know what is going to happen to me, to my kidneys. Nephropathology literature is overwhelmingly concerned with diagnosis. This talk will focus on the histologic findings on routine light microscopy that correlate with future renal function. And as we'll see, histologic prognostic factors primarily relate to chronic and not acute lesions. To approach this issue, we need to understand where we have been and where we should be going. In the past, researchers focused on the question, what histologic findings best correlate with current renal function? Now we've moved into an era where the questions addressed are, what histologic findings best correlate with future renal function, and address secondary issues such as, are they independent of each other and of clinical factors? Are they diagnosis specific or universal? What is the role of aging? And can IF and EM contribute to these answers? Renal biopsy rates are increasing, but most CKD never gets biopsied or gets biopsied too late. And so the question is, can we use biopsy findings to understand risk factors and mechanisms of progression, predict progression in individual patients who are biopsied, and learn to predict prognosis without the biopsy using non-invasive biomarkers. We are not there yet. Current models of progression risk are entirely based on demographics, clinical parameters, and lab findings. Let's look at the initial studies in the past which addressed what histologic findings best correlate with current renal function. Like many things, our story begins in 1968 with the publication of this groundbreaking study in The Lancet looking at 50 biopsy specimens with glomerular disease only. Most patients had nephrotic syndrome and systemic diseases were excluded. They noted a highly significant correlation was found between the extent of tubular damage and creatinine clearance, plasma creatinine, and the ability to concentrate and acidify the urine. A less significant correlation was found between the extent of the structural changes in the glomeruli and those same clinical parameters. 2 years later, a more comprehensive study yielded images that established the classic teaching that IFTA is more important than glomerulosclerosis in predicting both current and ultimately future renal function. But the authors did not adjust comprehensively for known confounders such as clinical diagnosis, eGFR, and proteinuria. It took 20 years for the next step. This larger study, including non-glomerular diseases, introduced some important new concepts. The importance of interstitial volume and tubular epithelial area, including the medulla. With foresight, they point to the central role of peritubular capillaries and their relationship to IFTA. But there was still no multivariate analysis to show superiority over clinical parameters alone, and no data showing progression risk. As a result of these insights into chronicity, in subsequent years, there has been a tremendous focus on understanding the mechanisms underlying IFTA, generating these proposed mechanisms. Renal pathologists have also incorporated chronicity into most classification systems, yielding a great deal of diagnosis-specific data useful in patients with that particular disease, but of uncertain universality. And finally, in the past few years, a universal classification for chronicity itself, independent of specific diagnosis, has been proposed. It involves the classic lesions that we've been talking about, although with regards to vascular disease, focuses exclusively on the arteries and gives a binary score. Also, this schema fails to take aging-related changes into account. In recent years, investigators have begun to address these higher order issues and ask what histologic findings best correlate with future renal function independent of clinical parameters. In particular, I'd like to share with you the results of our ongoing studies. The Boston kidney biopsy cohort has begun to address these issues using a prospective observational study of 776 individuals undergoing native kidney biopsy at 3 tertiary care hospitals here in Boston. Biopsies were adjudicated for semi-quantitative scores in 13 categories of histopathology by 2 experienced renal pathologists blinded to the original report. Global glomerulosclerosis was graded as age-related or pathologic, and multivariate analysis was used regarding detailed medical history, diagnosis, blood and urine samples to correlate with the histologic findings. As you can see here on the left, our case mix is pretty typical of the indications for biopsies and the diagnoses rendered for a clinical practice, at least here in the US. On the right, you can see the listing of the 13 lesions by glomerular, tubulointerstitial, and vascular compartment, and the distribution of their severity in the biopsies. Histologic parameters were correlated against both eGFR and proteinuria and yielded somewhat different results, as indicated here by the asterisk. This slide for eGFR shows that most of the lesions are the usual culprits, but there are some unexpected findings. Arteriolar disease, inflammation in fibrosed interstitium, and acute tubular injury. In contrast, correlations for proteinuria included glomerular lesions such as segmental sclerosis, mesangial expansion, and endocapillary inflammation. And interestingly, while arterial lesions were not significant with regards to proteinuria, arteriolar sclerosis remained highly significant. Most importantly, following multivariate analysis, 4 chronic lesions were found to be predictors of kidney disease progression independent of clinical predictors. Here are the graphs for age-adjusted global glomerulosclerosis and for interstitial fibrosis and tubular atrophy. Most notably, both sized blood vessels were significant. Pathologists are not always careful to evaluate these two separately, but it must be recalled that different sized vessels have different types of lesions. The recent universal chronicity score ignored arterioles, but these findings suggest otherwise. And although chronicity in the two-sized vessels are modestly correlated, they can diverge and should be scored separately. In conclusion, global glomerulosclerosis that exceeded the age expected, IFTA, and arterial and arteriolar sclerosis associated with progression even after adjusting for clinical predictors. Age-related global glomerulosclerosis alone was not associated with an increased risk of progression. The chronicity score was validated, but did not change prediction appreciably. Interestingly, perhaps not a surprise for those who follow the Banff classification, inflammation in IFTA was associated with an increased risk of progression, while inflammation in preserved interstitium was associated with decreased progression, probably because that is treatable. Our study comprised patients who underwent native kidney biopsy due to suspicion of a primary kidney disease, and therefore these findings cannot be extrapolated to a healthy or aging population. Furthermore, as we alluded to before, post-biopsy therapy was not taken into account. These I would consider to be the two biggest limitations of our findings. Here is a very recently published single center and single pathologist study that includes AKI and allograft biopsies and essentially confirms our findings. In their discussion, they note, even after accounting for the exposure variables queried, the majority of the hazard for kidney failure remains unexplained. Thus, considerable opportunity remains to improve the predictive value of a histologic interpretation by uncovering novel molecular markers. Given the continued relevance of glomerulosclerosis, we have to ask, what if not all sclerosis is the same? What if cortical depth makes a difference? An important limitation in biopsy material is that we often don't know what part of the cortex we're looking at. This nephrectomy study, using wedges of cortex with glomerulosclerosis categorized by depth, suggests that location is important and that not all sclerosis is the same. Although glomerulosclerosis associated with decreased eGFR independent of cortical thickness, they clarified that there are three different patterns as seen in the cartoon. On the left, disease-related sclerosis independent of age, which was found throughout the cortex, while diabetic-related sclerosis was found in the deep nephrons at the corticomedullary junction. In contrast, age-related glomerulosclerosis, primarily due to chronic vascular disease, was found in the superficial cortex. Just released in the past few weeks is another nephrectomy study that parallels these findings. As you can see in the graph, the relationships remained linear. In other words, the association between eGFR and histologic changes did not vary with age. While the eGFR was lower in older groups, the relationship between histology and eGFR was preserved. And they noted hopeful news that even in the 72 to 91-year-old group, a significant subset had excellent renal function and limited histologic changes. Allograft studies provide a unique context to examine prognostic factors. This group had previously found that nephrosclerosis, larger nephron size, and low nephron number modestly predict clinical parameters in the donor at 4 months after donation. Here, in their analysis of 2293 kidney donor-recipient pairs, the authors identified subclinical nephrosclerosis, which they defined as IFTA and arteriolar hyalinosis, larger nephron size, but not nephron number, and smaller medullary volume as structural predictors of death-censored graft failure that were independent of both donor and recipient clinical characteristics. And as we saw, age-related loss of nephrons occurs primarily with superficial and not deep glomeruli. Since the medulla is composed of tubules from the deep glomeruli, loss of medullary volume, as noted here, may reflect loss of nephrons that is more pathologic than age-related in nature. Finally, I'd like to note this pioneering study from the Neptune group that opens up a new direction. They looked at 12 glomerular EM descriptors and showed an association with clinical outcomes for the 12 glomerular EM descriptors noted, reflecting the status of podocytes, endothelial cells, and the GBM, both individually and also as EM profiles after descriptor-based consensus clustering. In their analysis, severe foot process effacement and microvillus transformation, individually and as a component of clusters, were associated with proteinuria remission. In contrast, prominent endothelial cell and glomerular basement abnormalities were associated with loss of renal function. In conclusion, chronic changes are predictive of progression independent of clinical parameters and should therefore be listed separately in the diagnosis. Chronicity is also a diagnosis. This is true whether the chronicity is due to the primary diagnosis or due to comorbidities. Arterial and arteriolar disease should be separately evaluated. There's a great need for standardization of vascular lesion descriptors and their grading systems. Integration of histopathology with cutting-edge imaging techniques may be very promising, for example, in extrapolating from a limited biopsy sample to the entire organ. There is a need for further development of artificial intelligence morphometry algorithms and molecular diagnostics in kidney biopsy tissue, but it must be guided by our expanded understanding of the morphologic features of progression.
Thank you very much, Dr. Stillman, for your very interesting talk. So it's now time for the questions and answers. If I may, I would like to start with Professor Nast, but everyone is here, okay? So Professor Cynthia Nast, I have a philosophical question for you about artificial intelligence, because you know it's a very hot topic in many fields and in renal pathology. So how do you imagine that we will be using artificial intelligence in the daily practice in the next years?
Well, can you hear me?
Yes.
Okay. So I think it's not going to happen next year. It's going to take a number of years for it to get to where it can be used clinically. I think we're looking at 5 to 10 years maybe. And artificial intelligence will never replace the pathologist. It will be an adjunct to how pathologists practice. So I think we can use it to, for example, quantitate the tubular atrophy and interstitial fibrosis Dr. Stillman was just talking about, to quantitate global glomerulosclerosis, maybe even to identify where those lesions are, to quantitate some maybe novel features that I know Dr. Barasoni is probably going to talk about more toward the end of the program. But it will take a pathologist to integrate those with the clinical features, what's going on with the patient, and to come up with a diagnosis. It's just will allow us to have more quantitated, accurate, detailed information coming in, but we will still be needed to make the diagnosis and do the interpretation. So, and it'll make our jobs a little bit easier because we won't have to sit there. Is this 20% tubular atrophy interstitial fibrosis or 27%, which would make it a T0 or a T1, for example, in the IgA MES score. So it may allow us to do a better job, but I don't think it will ever replace us.
Okay, thank you very much for your great answer.
I don't know, Isaac, do you have any comments on that?
Well, how could I disagree with you? I think with regards to IFTA, we've already, several years ago was shown that pathologist eyeball is pretty close from a practical point of view to image analysis, particularly when you base it off of trichrome sections. And the whole question of how precise do you have to be with regards to IFTA is another one. After all, we are looking at a very small portion of the kidney. But I do think that we have to get more sensitive to where the fibrosis is. And if we can identify it as subcapsular, for example, the significance of it, even though the number is the same, may be very different. Unfortunately, many biopsies, we don't always know at what level of the cortex we're looking at.
If I may add something as well, from the perspective of clinical nephrology rather than pathology, I think artificial intelligence is making a lot of progress in image analysis, but also in analysis of electronic health records. And so I'm involved in several algorithms working on picking up early kidney disease from just based on patterns of lab values and things like that. And I think there are a lot of exciting applications of artificial intelligence also for early detection of kidney disease and also guiding the management for non-nephrologists, since, of course, kidney disease is very prevalent. So in addition to image analysis, I think there are a lot of other exciting applications potential in nephrology.
I think the ultimate advantage of image analysis will be to detect lesions that are not appreciable by the human eye, types of changes that a pathologist cannot any human being, even a renal pathologist cannot recognize, and to develop new types of lesions based on the image analysis, which will add another level of diagnostic evaluation.
Yeah, and that's going to take quite some years to identify and validate.
Yeah, I don't think we have to worry about being replaced for that.
Thank you very much. Do we have a question from the audience? Agnieszka?
Yes, we have a question to Cynthia from
we can't hear you.
We can't hear you. Now you can
Maybe
hear
I
me
can
now?
continue with the question, or Dr. Stillman. Do you think we should score the IFTA on our native kidney biopsies?
Absolutely. That's one of the central messages of my talk. Now, many people use percentages. I've done enough image analysis myself to know that let's say the way a cardiologist evaluates stenosis of arteries, that is highly reproducible in terms of the numbers that we give, but it doesn't necessarily closely correspond to reality. So if we say something is 40%, that is reproducible, but it may not really correspond to 40% based on image analysis. We're really just kind of giving it a score of 1 to 10, 1 to 100, and assuming that that reflects the actual percentage. So most of the time, I don't even use words, numbers. I use words, and as a typical pathologist, split the grades of minimal, mild, moderate, and marked. One area which we're starting to look at, and I think needs more attention, almost everybody says over 50% IFTA is just, that's it, you're shot over 50%. But I'm not so sure that everybody above 50% is the same. And I think we need to have more discrimination at the lower end of renal function because we don't really know how much is recoverable when you're over 50%. We don't, in general. If I tell you, a patient has an eGFR of 30 or 20, we don't really know that well what is the expected histological correlate of an eGFR of 30. And that's something that I think we're looking into, but I think we need to be thinking about more. It may, just putting everybody into an over 50% may be too crude a grading system.
Thank you. Professor Grenda, do you have a question?
Yeah, I just read a question from the audience to Dr. Stillman. How do you distinguish moderate from severe arteriosclerosis, problem of tangential sectioning?
Yeah, well, there's a huge problem, which is we've been honing and refining the way we talk about glomerular lesions for decades, while our vocabulary and our grading system for vascular disease is woefully inadequate. And although our glomerular vocabulary deals with issues such as distribution of lesions, focal diffuse, segmental global, that sort of thing, when it comes to vascular disease, there really is not any strong consensus. So for example, if you see one arteriole with, marked hyalinosis, however you define that, but most of the others show mild hyalinosis, what do you call that? There's no consensus. Some people say, oh, go by the worst possible lesion and grade it based on that. Others say, no, you have to look at the whole, whatever vessels you have in your sample and try and create a gestalt of the whole situation. And we need better ways of measuring these things. The technique that Maurer used, where he went through every single arteriole and gave a score based on the hyalinosis, and then you can talk about the populations and the distribution, is perhaps the most scientific way of doing it, but I don't see that renal pathologists are going to be able to do that. Maybe that would be a role for image analysis, but as we all know, once you're dealing with diseased arterioles, sometimes they can be very hard to distinguish from atrophic tubules. Will we be able to get around that? So there are a whole bunch of issues, but I feel like, first of all, we need to be paying more attention to this problem and coming up with some sort of system to evaluate these things in a routine way so that we can start looking at studies.
Yeah, another issue is sometimes the smaller arteries will just have some muscular hypertrophy and no fibrosis. But if you get an arcuate artery in the biopsy, that can show quite a bit of fibrosis. So you can have a disconnect between the larger intrarenal arteries and the smaller intrarenal arteries. And how do you reconcile those? What is the significance of that? So those are just other questions that need to be addressed. And we still have lots of work to do. So we're not going to be put out of business yet.
No.
Ask a question, Krzysztof. It is a very fascinating field that you've been talking about to us. What is your opinion about the role of the genetics in everyday diagnostics of renal diseases? Because apart from the involvement of genetical studies in searching for elucidation of pathogenesis of several of patterns of injury and generally diseases, it is a question about the role of genetical examinations in the individual patients. Because my understanding of this issue is that we should think more and more about incorporating diagnostics into the diagnostics, the genetical studies as well. What is your opinion about it? And also, if you feel that that it is needed, maybe you feel that it is needed more in some of the patterns of injury, or if you will, diseases, and in other is not that necessary.
Yeah, I mean, I think this is an excellent question. And, I think to some degree, this is already happening. So I think at least in the US, I think genetic diagnosis is incorporated more and more frequently. I come from a place here at Columbia where we do it routinely as part of kind of our research studies. So it's, I think it's a difficult question because, of course, practice patterns are different. The accessibility to genetic testing and things like exome sequencing also vary by country, and there are cost issues related to this. So it's very hard to come up with a uniform set of recommendations, when diagnostic testing should be employed. But at the same time, I think a reasonable diagnostic strategy is if the genetic diagnosis is suspected, the cause of renal failure is unexplained, or it's an early onset disease, or there's really strong positive family history, you start, I think, with kind of sensible panel sequencing based on your best diagnostic assessment of what might be going on. But then if panel sequencing is negative, I think it's reasonable to move on to exome sequencing. And I think that paradigm is now being accepted by several countries. And then if exomes are negative, because that is also a possibility, exome sequencing has many limitations and can be missing certain forms of genetic variants, for example, CNVs, then I think it's reasonable to also move on to other forms of genetic evaluation like SNP microarrays for CNV detection, or even whole genome sequencing. And there are programs like that in the UK, for example, where genome sequencing is routinely performed for patients that have negative panel sequencing. So, so I think it's a difficult question. It's definitely an evolving field. We are kind of a little bit spoiled at Columbia because we have access to exome sequencing on a research basis for our patients. But I think what we are trying to do is really come up with sensible ways of approaching this problem and improving diagnostics by incorporation of these technologies. I don't think there's kind of a recipe how to do this yet, but we're certainly interested in developing one.
Thank you so much.
Thank you. We need to move forward. So all questions
Agnieszka,
that
I'm
remain...
not sure if that answers your question.
All questions that remained unanswered will be addressed by the lecturers via the chat box later on. We shall see you in 5 minutes at 4 p.m.
for the second part of this session. Thank you so much.
Thank you very much.
Thank you very much.
Are those real
let
or
us
fake
move
books in your
to the
background,
next
Dr. Grenda?
part of
Oh,
the
yeah.
session.
Are they real?
Oh, okay. I'm
Bardzo dobrze.
Session.
Let us move to the next part of the session. Professor Grenda.
Okay, ladies and gentlemen, I have a pleasure to introduce Dr. Jeffrey Hodgin, who is the Associate Professor of the Department of Pathology in University of Michigan. And he is an expert in classic and digital pathonephrology with several papers on FSGS, lupus nephritis, podocytes, and other aspects of pathomorphology. And he will deliver the talk about FSGS, where are we now and where are we going? Floor is yours.
I'd like to thank the organizers for inviting me to present today. As you can see, my title is FSGS, Where Are We and Where Are We Going? And as you can see, that's a pretty broad topic to cover. So I'm certainly not going to be able to cover everything in the 20 minutes, but I hope I can cover some things that are useful. These are my disclosures. So FSGS is increasing worldwide in prevalence. It's a major contributor to end-stage kidney disease and a leading glomerular cause of end-stage in the US. And as you know, it's a histologic pattern of glomerular injury and not a single disease. And importantly, it represents a diagnostic challenge, and it requires close collaboration between many different players, the patient, the family, nephrologist, pathologist, geneticist, and it requires a great deal of information from clinical history, laboratory testing, the biopsy, etc., to put everything together. FSGS is a disease of heterogeneous morphologic patterns, all of which share some similar qualities, such as obliteration of the capillary lumen in a segmental fashion in the glomerulus. In 2004, a morphologic classification for FSGS was generated called the Columbia classification. Here showing 5 different morphologic types: the tip lesion, perihilar, classic NOS, cellular, and collapsing. And as you can see, it's on a spectrum of good prognosis to bad prognosis, with the unique variants tip lesion, for example, having a particularly good prognosis, more akin to minimal change, and of course collapsing have a particularly poor prognosis. As you can see by one of the many studies that have looked at this, Thomas et al. In 2006, showing the worst survival with collapsing. Of course, the injury feature that is common amongst all of these in FSGS is podocyte injury and loss. And as you can see here, multiple factors can work together to lead to podocyte injury, leading to proteinuria and glomerular sclerosis. And of course, this injury is what we look for in the electron microscopic images, as shown on the right, normal appearing podocyte foot processes at the top and then effacement at the bottom. We have known for some time that the insult to the foot processes that leads to effacement could be reversible, responding to treatment to the injury that could be either extrinsic or intrinsic. And the idea being that sustained injury or a second hit can lead to irreversible podocyte stress, detachment, or apoptosis, that this can spread from cell to cell, and this is what begins the process leading to segmental and global glomerular sclerosis. A review by Rosenberg and Kopp discusses the etiologic classifications, putting it into 6 forms of FSGS. One of the more important being the primary or idiopathic FSGS, thought to be due to a circulating factor, perhaps a cytokine. Here listing some possibilities. In the recent years, research showing CLC1, perhaps ApoA1B, anti-CD40 antibody or SUPAR being the elusive cytokine. These patients have an acute onset of edema, generally younger age, very high-grade proteinuria and nephrotic syndrome, and the pathology with electron microscopy showing the diffuse podocyte foot process effacement. These patients may respond to immunosuppressive therapy, and possibly it recurs after transplant. The adaptive form of FSGS, believed to be a mismatch between metabolic load and glomerular capacity, often a hyperfiltration injury, perhaps in the setting of hypertension and obesity, is common. These patients either have a reduced renal mass or an increased single nephron GFR, as I mentioned, hypertension and obesity. They can have any level of proteinuria from subnephrotic to full nephrotic syndrome. They often show glomerulomegaly. Perihilar FSGS is associated with this, and they classically have a partial foot process effacement on EM studies. Immunosuppression is not the appropriate treatment, but they can respond to RAS antagonism, and it's unlikely to recur after transplantation. The genetic form of FSGS is quite broad in that there are 38 or more genes that have been identified to cause or contribute to the disease process leading to FSGS. I'm hoping that earlier or later talks will be able to go into these sorts of things much more deeply than I can here, but these are Mendelian or mitochondrial inheritance genes. Many of them are in the podocyte, the gene products in the podocyte, and their injury with mutations occurs there. They can have a family history, but it may not be remarkable. They can have any level of proteinuria. The pathology is unfortunately variable. They usually do not respond to immunosuppression, and it's unlikely to recur after transplant. The identification of genetic variants in APOL1 in patients with FSGS has been an important discovery for FSGS and related diseases. APOL1 is a major form of FSGS in countries with individuals from sub-Saharan Africa. The effect is largely recessive, requiring 2 alleles, although 1 allele may increase the risk, such as in the setting of HIV infection. In the United States, approximately 40% of end-stage renal disease is attributed to FSGS occurs in blacks. And of this, 72% is associated with APOL1 genetic variants. Thus, approximately 1/3 of FSGS in the US is associated with APOL1. These patients may have a family history, but it may not be remarkable. They present with any level of proteinuria, and their pathology may resemble primary or adaptive forms, so that's not very helpful. They may respond to treatment, and it possibly could recur after transplant. So there's really quite a lot that's not known here. And the last 2 forms I want to mention quickly, the infection and inflammation associated, such as with HIV infection, thought to be a role of interferon and other cytokines there. Again, they can have any level of proteinuria and a variable presentation with the morphology. The treatment to be, of course, to treat the infection, and the medication associated, again, presumed direct effect on the podocytes. Bisphosphonate literature in the past on that, and lithium, of course. They can have any level of proteinuria and a variable pathology, and of course the treatment being stop medication. I've already discussed the risk prediction based on morphology, and of course we know the clinical factors include things like degree of proteinuria and renal dysfunction, but this graph shows some of the biomarkers from blood, kidney tissue, and urine that have been published in the literature in past years. I only really want to highlight a couple. For example, in the blood levels of SUPAR initially found to be elevated in idiopathic FSGS, but since then there's been multiple papers and some controversy about SUPAR as an FSGS causal factor. I want to say a little more in detail about in the kidney tissue, especially gene expression, but one example, in 2004, the CD80, and then 2012, CD44 in parietal cells in idiopathic FSGS. And then, of course, a lot of effort to try to find things in the urine that as biomarkers can be used as biomarkers, including like urinary ApoA1B. For the transcriptional studies. I want to go into a tiny bit more detail because I'll talk about them again, that in 1994 we had microdissection and RT-PCR and then individual podocyte qRT-PCR. But since 2002, we've been able to do genome-wide gene expression analyses, first starting with microdissection arrays, and then as early as 2013 with RNA sequencing, and then much more recently, single-cell RNA sequencing and also single nuclear RNA sequencing. So as I mentioned, the risk prediction with pathology, we already discussed that, and then other things that are used, generic features for any type of disease in the kidney, you look IFTA, global glomerular sclerosis. These are things that we put in our reports to try to help guide the clinician. However, there's still a lot of difficulty and challenges in trying to understand what to do with any patient that comes in. And in discussions with my clinical colleagues, they discuss multiple things that they have to put together, as I had mentioned earlier in the talk, in order to get an idea of what to do with that patient. And it's very challenging. So in order to address the where are we going, I wanted to talk some about joint efforts from large observational cohorts with the idea to get a better understanding of at the mechanistic level. One of being CureGN, started in 2014 with a plan to enroll 2,400 patients with minimal change FSGS, membranous and IgA nephropathy, and then the Nephrotic Syndrome Study Network, or Neptune, which is the one I'm going to talk about in more detail. So Neptune is a prospective observational cohort with patients enrolled at time of biopsy. The data and samples are prospectively collected in 4 to 6 month intervals over, it says 36 months here, but more than that. We've have up to 755 cases to date, probably more than that at this point. And as you can see, a lot of data, clinical data collection and biospecimen inventory, of course, the renal biopsy, blood and urine, and then a number of core and ancillary data sets, such as digital histopathology scoring, and molecular analysis. So the Neptune pathology group has been employing the digital pathology protocol and scoring system for many cases in Neptune for some time. Each case, the slides are scanned to whole slide images and entered into a repository. The glomeruli for each case are annotated so that one can follow any single glomerulus through all the sections to make sure that it's fully scored. And the scoring system is an observational data, what we call descriptors, for quantitative assessment of glomerular, vascular, and tubular-interstitial features. This is largely been led by Laura Barasoni, and it's objective and quantifiable. Using this, we can generate glomerular descriptor-driven patient clustering. Here showing glomerular descriptor profiles, 37 were scored and analyzed from 221 patients with minimal change in FSGS. We performed unsupervised hierarchical cluster analysis to look for distinguishable patterns. And as you could see, we have clusters X, Y, and Z. Cluster X seems to have, or does have, more of the features than Y and Z having the fewest. If you look more closely at what are the features that drive the clustering, here are the top 10, including things like global sclerosis with and without hyalinosis, obsolescence, and segmental sclerosis of unknown location, periglomerular fibrosis, etc. Looking at how these clusters associate with clinical outcomes, you can see that cluster letter X, the one that had the most of the features or the descriptors, definitely has the worst outcome as far as 40% reduction in GFR going to end stage, whereas clusters Y and Z are very similar. For complete remission of proteinuria, again, cluster X is the worst, and Y and Z are much better, although there is a difference between Y and Z. Comparing the descriptor-based cluster analysis to a Columbia classification, shown here with the Sankey diagram, you can see that there's a fair amount of similarities, but there are some differences. For example, the minimal change group, The one that does rather well, it indeed overlaps quite a bit with cluster Z, the one that does rather well as far as the outcomes. But there's some in cluster Y and even a few in cluster X, the one that did quite poorly. Similarly, the FSGS collapsing, there are collapsing that are in cluster X, as would be expected, but some in Y and some in Z as well. 126 of the patients had glomerular gene expression, and we could use this for comparative analysis, here showing cluster X versus Y plus Z, or Z versus Y plus X, etc. We can see that cluster X has almost 2,000 differentially expressed genes compared to the other two clusters, about 1,700 in Y and only 75 in cluster Z. An analysis of the pathways that are enriched in cluster X versus Y plus Z shows a list of canonical pathways that are enriched for inflammation and innate immunity. Looking at the upstream regulators predicted to be activated, we can see the top ones, TNF, interferon gamma, IL-1 beta, and TGF beta 1, which are well known to be involved in kidney disease. So for descriptor scoring, renal pathologists observe multiple features of the structural complexity in the kidney not captured in our current classification system, and we think those features have important clinical and biological relevance. Moving on to the last part of my talk, the wealth of data that can be obtained from an observational cohort can allow a glomerular disease understanding in mechanistic terms. Here, a biopsy-centered clinical and molecular phenotyping that allows a multi-scalar data integration. This includes histology, some of the things I just showed you, but of course integrating with clinical phenotype, genomics, transcriptomics, proteomics, metabolomics, etc. And that this can help with patient profiling and looking for pathway activation at the patient level, either in the kidney biopsy or non-invasive surrogate markers, blood and urine. So the Neptune focus on precision medicine, in the framework for Neptune 1 and 2, was designed to map pathways in nephrotic syndrome patients, including FSGS. And in the next iteration, Neptune 3, the main goal is to test the precision concept in the context of ongoing clinical trials, called the Neptune Pre-Competitive Public-Private Partnership Platform, which is difficult to say, with a hypothesis that we can establish a framework to match patients to clinical trials based on the assessment of the disease mechanism. This slide shows the overall strategy for unbiased hierarchical clustering of gene expression to identify molecular subgroups. Step 1, the kidney biopsy tissue can be microdissected, RNA extracted, and profiled. The data can be used to cluster the participants based on the gene expression, forming molecular data-based patient subgroups. These can be tested for association with clinical phenotypes, and then used to place the patients into their clinical context to identify networks and downstream transcriptional changes. Now, this shows the unbiased clustering of Neptune participants with minimal change in FSGS. This is based on transcriptional profiling of the tubular interstitium, and we can see 3 clusters that were identified and associated with outcome. On the right, you can see that cluster number 3 had definitely the worst outcome as far as GFR and end stage. And then analyzing the gene expression in that cohort or in that cluster, one can look at transcriptional readouts for predicted activation of certain regulators, such as in this case the TNF-alpha. So these 30 or so genes suggest that TNF-alpha is upregulated, or activated in cluster 3. Indeed, when you look at each cluster specifically for this list of TNF regulated genes, you can see that this TNF activation score is definitely in cluster 3. This can be used for potential patient stratification based on TNF activation. And one can go on and add others to this, such as JAK-STAT pathways, endothelin pathways, etc. This type of data is used in the Neptune match to match patients to trials in nephrotic syndrome. Step 1 being patient recruitment and integrative analysis with the molecular profiling or the histology, as I showed you before. This can be analyzed in the molecular nephrology board that seeks to categorize the patients as to which trial they should be enrolled in, basically matching the patients to the trials based on the molecular stratification. And so the outcome-associated molecular signatures can be identified within FSGS to identify novel therapeutics. Beyond Neptune and CureGN, there are multiple observational cohorts that we might be able to do similar things with. I'd like to highlight H3 Africa, which has a lot of nephrotic syndrome patients in as well. And of course, KPMP, which goes into a lot more detail than Neptune does as far as molecular analysis, including things like proteomics, metabolomics, etc. And so I'll just end there. Thank you very much.
Thank you very much for a great talk. Then we move on to the next speaker, and the discussion will be at the end. And our next speaker is Professor Rachel Lennon. She is a Wellcome Senior Research Fellow in Clinical Science at University of Manchester, and Honorary Consultant in Pediatric Nephrology at the Royal Manchester Children's Hospital. And her research interest is mainly focused on glomerular disease in adults and children. And among other achievements, Rachel's research group have developed, optimized, and utilized proteomic approaches to define the molecular landscape of cell matrix adhesion into the glomerulus. And the topic will be update of type 4 collagen disorders. Rachel, floor is yours.
Hello. I'm delighted to be part of the 4th International Renal Pathology Conference, and thank you very much to the organisers for the invitation. My talk is an update on type 4 collagen disorders. I'm Rachel Lennon, and I'm based in Manchester in the UK. I'm a paediatric nephrologist, and I work together with this wonderful group of colleagues at the Royal Manchester Children's Hospital. It was opened by the Queen in 2008 and is one of the largest children's hospitals in Europe. I'm also Professor of Nephrology at the University of Manchester, and I lead a team of researchers at the Wellcome Centre for Cell Matrix Research. So Manchester's famous for lots of things, and we were due to host the 13th International Podocyte Conference this year. We've postponed it, and it now has a new date in July 2021, so please do save the date. So in today's talk, I'm going to run through background about matrix and basement membranes, talk about Alport syndrome and an altered signature of matrix in the glomerulus. I'm going to talk about how we've used volume electron microscopy to study glomerular ultrastructure and to give evidence of podocyte invasion into basement membranes, and to finish up by talking about treatment options on the horizon. So this audience won't need any introduction to our kidneys, to nephrons, or even to the glomerulus. But just to highlight in this slide that the specialized glomerular capillary wall is the filtration barrier. And we know in the glomerulus that there are unique cells and matrix which are important for glomerular function. And probably the most striking cell in the glomerulus is the podocyte that we've captured here using volume electron microscopy. And we've colorized the image using segmentation. And this just shows the beautiful complexity of these cells. Of course, they line the outer surfaces of the glomerular capillaries, which are lined by endothelial cells, and separating the two cell types is the glomerular basement membrane. So what about matrix within the kidneys, matrix compartments? Well, we can broadly think of matrix as basement membranes or looser interstitial matrix. And these are the varieties that exist within the kidneys. And using volume electron microscopy, we use serial block face scanning electron microscopy, we can see the beautiful ribbon-like structures of the basement membrane here, and we can use segmentation to color and to identify connections between these ultrastructural features. And this enables, the volume EM enables us to find defects within structures that are far more difficult to appreciate using transmission electron microscopy. So this is what basement membranes look like. What are they made of? Well, many decades of work have led to our understanding about basement membrane assembly. And there's an essential requirement for a laminin network upon which the type 4 collagen network assembles. And these two crucial networks are connected by a number of proteins, including perlecan and nitrogen that cross-link the networks, as well as many other components. And importantly, they also connect to cell surface receptors. So type 4 collagen, like all collagens, is formed from a trimer, which is a triple helix. So 3 alpha chains assemble as a triple helix. And there are 3 isoforms of type 4 collagen that we know about: the 112 network, the 345 network, and the 556 network. And these networks form by dimerization at the non-collagenous domain, and then further polymerization of the network through cross-linking at the 7S domain. And all 3 of these networks exist in the kidney. The 112 network is by far the most ubiquitous and is localized in the glomerulus as well as the tubular interstitium. The 345 network is more restricted to the GBM, and this is the network that's important in Alport syndrome. The 556 network is localized to Bowman's capsule, but also to tubular basement membranes. However, it's not just type 4 collagen and laminin in the glomerular matrix. It's a much more complex picture, as most things are. And in order to harness this complexity, a number of years ago, we used proteomics to define the human glomerular matrosome. And this is a complex extracellular environment. And in this study, we identified over 140 structural and regulatory matrix proteins. They're represented here on this protein-protein interaction network, where the circles are the proteins and the lines are experimentally confirmed protein-protein interactions. You won't be surprised to hear that the composition isn't static, it's dynamic, and it varies according to development and disease. And it also, matrix composition is also tissue specific. So if we look at normal tissues and the composition of basement membrane components, then many of these components are localized to many different tissues, and others have far more restricted expression. And what Mike and Franzi did was look at the relative expression in the tubular interstitium in pink compared to the glomerulus in green, and you can see distinct enrichment for matrix components, even within the same tissue or organ. So matrix is complex, and it's also specific, and no doubt that relates to the underlying function. So moving on to talk about glomerular disease and Alport syndrome, which will be familiar to many people. It's associated with an early phenotype of macro and microscopic hematuria, and it's caused by genetic variants in type 4 collagen genes, in particular the genes that encode the chains required for the alpha 345 network. The consequence of these genetic variants is impaired type 4 collagen assembly in basement membranes. And that affects the kidney, where we see this typical basket weave appearance of the GBM, but also the cochlea and basement membranes in the eye. However, variants in type 4 collagen are not just restricted to rare diseases such as Alport syndrome. In fact, large sequencing studies over the last 5 years or so have shown a connection between Col4A variants and a much wider spectrum of disease. So in this study, a genome-wide association study in 19,000 individuals with diabetic kidney disease found an association between Col4A3 and diabetic kidney disease. And in this study from Columbia, then 3,000 adults with CKD had a high proportion of variants in Col4A3, 4, and 5. But it's not just related to the kidney. Col4A variants have been associated with a much wider spectrum of disease associated with coronary artery disease and stroke, and therefore increasing the association between type 4 collagen variants and human disease. The connection between FSGS and Col4 variants has become much clearer over recent years. And this study from Toronto investigated adults with FSGS, either proven on biopsy or individuals with proteinuria and a relative with FSGS on biopsy. And almost 200 individuals underwent whole exome sequencing. Not surprisingly, there were a high number of variants in podocyte genes. This was FSGS. But look at the number of pathogenic variants in the Col4A 3, 4, and 5 genes. So this connects these Alport gene variants with FSGS. And that's important because it's an opportunity for us to identify individuals with Col4A 3, 4, or 5 variants and then ensure that these individuals are tracked for kidney surveillance so that we can intervene should they develop persistent proteinuria. So coming back to abnormal matrix in the glomerulus, well, having defined the picture of the healthy matrizome, we were keen to look at the progression of matrix changes over the evolution of disease. And to do this sort of experiment, we needed to use a mouse model. So in collaboration with Jeff Miner, we used the Col4A3 knockout mouse, which has a really good phenocopy of the human kidney disease. And we looked really early. We looked in mice at 6 weeks. These are mice on a black 6 background, so they have quite a slow progression of their glomerular disease. And even at this point, if we compare the control mice to the Alport mice, so enriched in blue are proteins that are enriched in the control, enriched in red are the ones enriched to Alport, then we could already at this early stage see separation in terms of matrix composition. At this point, from an ultrastructural perspective, the Alport mice just have thin basement membranes. If we look at a later stage of more established disease, then the separation is far more evident. And the broad picture that we observed here was a reduction in basement membrane components and an increase in interstitial matrix components in the Alport mice. There was one signal in type 6 collagen that appeared up in the Alport mouse from an early stage from 6 weeks and was persistent. And we went on to demonstrate using super resolution light microscopy that the type 6 collagen was incorporated into the glomerular basement membrane. So here is the control scenario with a healthy, regular outline to the glomerular capillary highlighted by beta-1 integrin, but there's no type 6 collagen here in the basement membrane. Whereas in the Alport mouse, then there's an irregular, as you would expect, appearance to the GBM, and there's evidence of ectopic type 6 collagen. So this was in the Alport mouse. We subsequently looked at a number of other mouse models of kidney disease, but also at human kidney aging. And what's surprising is that we see a number of proteins that appear in all of these data sets. and suggests, therefore, that there's a signature of abnormal matrix in the kidney associated with disease and aging. And when we've taken this signature of proteins and looked across published and existing disease data sets from individuals with IgA nephropathy, diabetic kidney disease, and FSGS, then a number of these proteins are persistent. And again, the pattern is that there is a reduction in core basement membrane components and an increase in interstitial matrix. So our model here is that in a number of glomerular disorders, you go from having a healthy basement membrane to an early injury stage where there is already a change in matrix composition that is likely to impact on cellular signaling pathways. And then rather than replenishing basement membrane components, there is interstitial ectopic matrix being deposited that has a knock-on consequence in terms of outside-in signaling. So, compositional change through the course of disease, but also structural change over the evolution of disease. And in the next few slides, I'll talk about how we've used volume electron microscopy to describe the progression of morphological change through disease. And we started off with the same Alport mouse with the Col4A3 knockout, and you can see an early, rather healthy looking basement membrane, but progressively changing in terms of abnormality. What we also found in this study was evidence of cellular parts of cells localized within the basement membrane. So you can see an abnormal basement membrane here, and a region of reduced electron density here. The advantage of having serial block phase scanning electron microscopy is that we have sections every 50 nanometers that we can move through and track these features. So we highlight them with segmenting and then join all of these up to create models. And when we did this, we were able to identify these regions within the basement membrane and connect them. And whilst it's difficult to appreciate something that's 3D and 2D, then what you can see from this view looking down onto the basement membrane is that the pink podocyte process reaches the outer surface of the basement membrane. But when we take away the meshing or the full coloring of the GBM there, we can see that it actually proceeds and goes into the basement membrane. So evidence of podocyte processes within the basement membrane. Now, we can't say that they're invading because they could have fallen into a gap in the basement membrane. But anyway, these processes certainly increase with age, and we've only ever found them in a disease scenario. What are they doing? Are they perhaps seeking matrix, responding to stiffness? Are they beneficial or harmful? Well, these are all questions that we're keen to pursue and answer. But the findings weren't limited to Alport mice. We found in other models of glomerular disease. And again, the numbers of invasions were different in terms of their length and how far they invaded into basement membranes, and also in terms of their association with thick regions of the GBM. We've also proceeded to look in samples from human biopsies, and this is one of a patient of mine who had X-linked Alport syndrome and an abnormal early phenotype, which led to us identifying a heterozygous variant in the FSGS gene myosin 1E. So what we can see here in this biopsy is this really abnormal basement membrane, and you can see a number of defects. And when you track these, you can see evidence of processes coming from podocytes and extending into the basement membrane. So moving on to think about treatment. Well, our current strategy and mainstay of treatment for patients with glomerular disease is to delay disease progression. So in the context of Alport syndrome and the wider picture of thin basement membrane disease, we definitely see variable progression. That could be due to genetic modifiers that we still need to identify, but there's also a link to environmental factors such as blood pressure. So our current management is to ensure lifelong surveillance, where we're aiming to reduce proteinuria by reducing hydrostatic pressure. And we can do that effectively by interrupting the renin-angiotensin-aldosterone pathway with ACE inhibitors or angiotensin receptor blockers. And by doing this, we know in Alport syndrome we can extend kidney survival by beyond 15 years. It's exciting that there are many new agents being investigated, but it's also important that we also think about the safety of these new agents as they come through. Thinking more specifically about therapies directed towards basement membrane disorders, then we can think about targeting mechanisms that we know are related. So that could be fibrosis or broader aspects of matrix biology. And if we think about the particular concept of can we repair abnormal and damaged basement membranes, then there's already, you know, a number of ideas and pipelines that are being investigated, which include gene editing technologies, where already in mouse models of Alport syndrome, exon skipping has been investigated. There's also the concept of replacing vital links of matrix components to connect basement membranes more effectively. And finally, proof of principle with protein replacement, replacing the entire protein that might be defective or absent. So in summary, I've whizzed through type 4 collagen, some aspects of basement membrane biology. I think crucially our goals are to improve the early detection of glomerular disease, and we can do that with genetics and hopefully increasingly with biomarkers. But this will be crucial to developing new therapies for children and adults with glomerular disease. I just want to finish up by thanking the team that I'm very privileged to work with in the lab. You can see we've been playing around with Zoom backgrounds over the last year, and also to acknowledge our wonderful collaborators and funding. And I'll finish up just by leaving the dates for the 13th International Podocyte Conference in Manchester next July. And I'd be very happy to take any questions.
Thank you very much for this excellent and fascinating talk. We have a time for questions. We have one from the audience to Jeffrey. The question is, how do the molecular classifiers of tubular interstitium relate to the findings in glomeruli?
Oh yeah, thank you for that question. It sort of highlights something that I wasn't particularly clear on in the talk, in that the tubular interstitial data that I presented was more of an example that we had, since I didn't have the glomerular. We do glomerular signatures to a certain degree, but the idea really is that we will have glomerular and tubular interstitial compartments for analysis and separately as part of the NP5.
Okay, I have a question about the point of no return of sclerosis in glomeruli. For instance, in people who are obese, so it's adaptive FSGS, when they lose the weight, to some extent, the disease will be stopped or reversed. The same is in drug-related FSGS. If the drug is stopped, the disease may stop or be reversed. From pathological point of view, in the single glomeruli, is there a point of no return when, even though you remove the cause, it will go further? Can you define this threshold?
Which is has been difficult to study because we don't biopsy people all the time just off the street. I wish we did, but you know, there have been studies to show that as far as segmental sclerosis, that there is a point where the process sort of becomes automatic, that the injury from podocyte shifts to the podocyte next to it, et cetera, and continues. And exactly where that is not entirely clear. You know, Wilhelm Kritz has many papers showing this process, but really can't show exactly where it becomes irreversible. So without type of studies, it's kind of difficult to answer that question.
I could just add into that, perhaps, that I think I find it fascinating in my practice in pediatric nephrology that we do see resolution in quite abnormal basement membrane. So with post-infectious GN, really, quite considerable changes there that do recover, or at least we see them functionally recovering. So that, I guess, tells us that there is some degree of remodeling and repair that is possible. And I guess, across all of our million and more glomeruli, there will be disease processes at different stages. I think it's really a really good question, but a really hard answer.
Yeah, and I should mention that there's some nice studies about resolution of disease in diabetics after pancreas transplant that we know of. Of course, that's mesangial expansion, but we see a reversal of the pathology feature in ways that we didn't expect to see. So I think there's a lot of opportunity and a lot of room to learn.
And for Rachel, this podocyte invasion, is it secondary to proteinuria or vice versa?
So we don't see this at all in wild type mice, and it's definitely associated with basement membrane defects. One of the limitations that we have when we're looking at human or even mammalian tissue is that everything that we're looking at is in a static manner, so everything's fixed. We don't have the opportunity to see the dynamics of these processes and whether they're moving. So we definitely see that the presence of cellular processes, that with the fact that we've got the volume electron microscopy stack, so where we've got 800 to 1,000 stacks through a single glomerulus, we can track these processes and see where they route back to. And they do route back, when you're looking in the peripheral loop of the capillary, they route back to podocytes, and they associate with defects in the GBM, and as such they are related to functional glomerular defects and proteinuria.
Okay, and as being pediatric nephrologists as you have, I have a question to both of you. There are children who are proteinuric, and they are nephrotic, and those who are resistant to therapy may go to FSGS after time. So we repeat the biopsy, and those who were minimal change now is having FSGS. But some do not. They are somehow resistant to heavy and recurrent proteinuria, even though they must lose podocytes. So what do you think is behind that? That some of those are resistant to this process, while the others go to FSGS and renal failure?
I mean, I guess one of the things that I think about in these children is, when we're sampling and we look down the microscope, we're looking, at a tiny component, aren't we, of the whole picture. And so whether we're really capturing a genuine global pathology that's relevant. And I guess it also tells us that what we can see doesn't necessarily reflect how those individuals will respond to the treatments that we can currently use.
Yeah, and I just want to add, I think that, it's yet another difficult question to answer. I think that we're at a good point where we have these cohorts, these large cohorts, where we're getting a lot of really high level clinical data, along with molecular on, I was showing you transcriptomic, Rachel has proteomic, and that this is what we believe is needed to answer questions like that, to have this, omic, multi-omic integrated analysis and very, very good follow-up.
Thank you very much. Marion, any questions?
I had a question for Dr. Lennon. I think you said that there is the alpha-6 chain replacing the mutated alpha chain during Alport syndrome in the glomerular basement membrane. Do you think there is a place for immunostaining of this chain?
You can certainly use chain-specific antibodies to detect all of the 6 type 4 collagen chains. In Alport syndrome, you do get ectopic production of a number of collagens. We've not particularly focused on whether, it will depend on the genetic defect in each case. So the 345 network is deficient or absent in all types of Alport syndrome. In the other network that I mentioned, so the 556 network, will also be compromised or affected in those with X-linked Alport syndrome and a COL4A5 mutation. So if you wanted to, so that should be preserved if you've got an autosomal cause for the Alport syndrome. We've not particularly looked at changes in the 556 network in the autosomal recessive setting.
Okay, thank you.
We have a question to Rachel. And, the question is the relationship between extent of podocyte extension into the basement membrane and glomerular disease type?
Yes, so I guess we've looked in a number of genetic mouse models predominantly, and it definitely associates with all of the ones that we've looked at so far in terms of the frequency of these protrusions, and they also increase through the evolution of the disease. So very early on, where there's very little functional effect of the disease, we don't see them, and it definitely does correlate with the degree of GBM abnormality. And yeah, there's still plenty of things that we want to ask about these processes in terms of what they might be doing, and whether in fact they are, potentially harmful by secreting proteases that further kind of worsen the problem by digesting basement membrane proteins.
Okay, we have more questions, but we are out of time a little bit. So I think there will be a chance to answer the further questions on chat. And thank you very, very much.
Thank you.
Thank you.
Nice discussion, Marion, for co-chairing.
Thank you very much.
Thank you.
Very nice. Bye-bye.
Bye.